All right, guys. Good morning, good afternoon, good evening, whenever you're viewing this. This is Miss Ford. I am going to be lecturing on your schizophrenia spectrum disorders for you. This is a lecture I'm recording in the event that we do not have class. So I will upload this to YouTube, and if you're watching it, you're already on YouTube having a look. Okay, so we'll go through the PowerPoint slides. I'll also be utilizing the text in front of me. So I apologize if you feel that I am reading to you, but I do want to touch on every area of these very important disorders, both schizophrenia and bipolar, which we'll get to next. Okay, so schizophrenia spectrum disorders. So what we're going to do is we're going to identify the schizophrenia spectrum disorders, discuss at least 3 of the neurobiological findings that indicate that schizophrenia is a brain disorder, differentiate among the positive and negative symptoms of schizophrenia in terms of treatment and quality of life. So schizophrenia, it's not very common. It only affects about 1% of adults. It is primarily characterized by psychosis, that is altered cognition, perception, and reality testing. 75% develop gradually, presenting at 15 to 25 years of age. So generally, the onset of schizophrenia is pretty early in life, most typically in the early 20s is when it's diagnosed. Child onset and late onset is very rare. Before we move on to the DSM highlights, I do want to point out what the book talks about on page 201. At the top of 201, under clinical picture, what you'll find is that children who later go on to be diagnosed with schizophrenia often would have had unusual characteristics years before the psychotic symptoms appeared. They did less well in school than their siblings, are less socially engaged, less positive, and exhibit unusual motor development. Actual childhood schizophrenia is extremely rare, carries a worse prognosis than adult onset version, and is usually diagnosed before the age of 12. Okay, so here we have the DSM-5 criteria. Recall the DSM-5, the Bible of mental health, the Bible of psychiatric illnesses. This criteria, all of which has to be met in order for a assertive diagnosis to be made. So 2 or more of the following for a significant portion of time within 1 month. Delusions. Okay, so what delusions are is an altered state of reality. So delusional thinking would be something like, I'm next in line to become the president, or I was abducted by aliens. Those are delusions. Hallucinations, those of which can be auditory in nature, visual, hearing or seeing things that are not present or that others do not see or feel. For example, tactile hallucinations. The best example of tactile hallucinations are feeling as if bugs are crawling on one. Disorganized speech, gross mental disorganization or catatonia. Catatonia is, the best way to describe it is rigid or no movement, just very stiff, unresponsive. Excuse me. Okay. Let me extend my time here. Excuse me. And negative symptoms. Diminished emotional expression or avolition. So negative symptoms are symptoms that would typically be present in a normal functioning person, but in a highly diminished sense, if that makes sense. I want to give you the definition directly from the text. So the absence of something that should be present, that is interest in hygiene, motivation, the ability to experience pleasure. Okay? And functional impairment of some time. These disturbances would have taken place for at least 6 months. Okay, we're going to skip the case study. So the epidemiology of schizophrenia. Again, the childhood onset is very rare, 1 in 40,000 children. There are no differences that can be accounted to race, social status, or culture, and it's most frequently diagnosed among males in urban areas. Okay. What you'll see in individuals who suffer from schizophrenia oftentimes are substance abuse. Nearly 50% of individuals with schizophrenia also suffer concurrently from substance abuse. 70 to 90% of individuals with schizophrenia also have nicotine dependence. Anxiety, depression, and suicide co-occur frequently in schizophrenia. Anxiety may be a response to the symptoms, such as the hallucinations or the circumstances that an individual with schizophrenia may experience, such as isolation, overstimulation, and may worsen those schizophrenic symptoms and prognosis. Okay. The book also goes on to indicate that approximately 10% of people with schizophrenia commit suicide. That's an 8.5 times rate greater than the general population. Physical health or illness are more common among people with schizophrenia than in the general population. The risk of premature death is 1.6 to 2.8 times greater than that of the general population. Polydipsia, this is interesting, can lead to fatal water intoxication, indicated by hyponatremia, confusion, worsening psychotic symptoms, and ultimately coma. Polydipsia occurs in an upwards of 20% of persons with schizophrenia, and a seemingly insatiable thirst that causes hyponatremia. So essentially, these individuals can drink themselves to death, and that is drink too much water to the point that they have imbalanced their sodium balances, and it can result in death. Okay. The etiology. So generally, when I talk about etiology throughout the course, when we talk about these different disease processes, these always come up: the biological, genetics, the neurobiological, the brain structure abnormalities. These are theories, these are hypotheses. We are not ever completely sure, but this makes the most sense in terms of how the brain functions, what areas of the brain have been proven to participate in certain functions and cognition. And the other piece of it is the pharmacology. So the manner in which some symptoms are either resolved or exacerbated based on the drug that the individual receives plays a role in leading to these theories and hypotheses. So genetic. Schizophrenia and schizophrenia-like symptoms occur in an increased rate in relatives of individuals with schizophrenia. Okay, so compared to the usual 1% in the population, having a first-degree relative with schizophrenia increases the risk to nearly 10%. There's a concordance rate in twins, how often one twin will have the disorder when the other twin hasn't. About 50 for identical twins and about 15% for fraternal twins. Excuse me, I misspoke. 50% for identical twins and 15% for fraternal twins. The degree to which genetic plays a role in schizophrenia is estimated to be about 65 to 80%. Okay. So I won't go into the specifics regarding the dopamine theory or the neurochemical hypothesis. You can read that on your own. It is quite interesting. However, you will not be tested on that material. Okay. And then with regard to brain structure abnormalities, so we use the brain imaging techniques such as CT and MRI and PET scan. Okay, so the brain abnormalities that have been found are enlargement of the lateral cerebral ventricles, third ventricle dilation, and or ventricular asymmetry, a reduced cortical frontal lobe, hippocampal or cerebral volumes, increased size of foci on the surface of the brain, reduced cortical thickness, and reduce connectivity to various brain regions. Again, very interesting. However, you will not be tested on this. And we continue with etiology. Psychological and environmental factors play a role in development, such as prenatal stressors, psychological stressors, environmental stressors, and prognostic considerations. So with regard to prenatal stressors, a history of pregnancy or birth complications is associated with increased risk for schizophrenia. Those risk factors include poor nutrition, specifically folate deficiency, and hypoxia. Infectious agents such as human herpes virus 2 and human endogenous retrovirus 2 are also implicated. Psychological trauma to the mother during pregnancy, death of a relative can also contribute to the development of schizophrenia. Other risk factors include a father older than 35 at the child's conception and being born in the late winter and early spring. Okay. Psychological stressors, stress levels increase cortisol levels, impeding hypothalamic development, and also causing other changes that precipitate illness in vulnerable individuals. Environmental factors such as toxins, and that's all we'll cover on that. I'm going to skip through the case study, and we're going to talk about the nursing process. Discuss how to deal with common reactions the nurse may experience while working with a patient with schizophrenia. We've gone through this a bit in lab, okay? But we'll discuss it just a tad more. And develop teaching plans for patients taking first generation and second generation antipsychotic drugs. Okay. So these are the phases of schizophrenia. The prodromal, or the onset, where there are mild changes in cognition and symptoms begin to develop slightly. The acute, where there's an exacerbation of symptoms. This is typically where you'll see a patient undergoing inpatient hospitalization. Stabilization, the symptoms are diminishing. There's a movement toward the previous level of functioning. And maintenance, or residual, where there's a new baseline established. You think about once a person is diagnosed with schizophrenia, or once a patient has been perhaps previously diagnosed, has some sort of exacerbation, and now has been stabilized, the maintenance or the new baseline is such that that individual is now experiencing a new normal at that point. Alrighty. Okay. So during the prodromal phase, this is assessment. The first step of the nursing process. During the prodromal stage, the general assessment, you'll assess for positive symptoms, negative symptoms, cognitive symptoms, and affective symptoms. Excuse me, let me go back here. I want to talk about these specifically. Okay. So positive symptoms, again, being the presence of something that is not normally there. So a positive symptom would be hallucination, delusion, bizarre behavior, paranoia, abnormal movements, gross errors in thinking. Negative symptoms will be the absence of something that should be there. So again, not wanting to participate in activities of daily living or hygiene, lack of motivation, or the inability to experience pleasure. Cognitive symptoms are often subtle changes in memory, attention, or thinking. Affective symptoms are symptoms involving emotion and their expression of that emotion. So positive symptoms are often associated with acute onset. Individuals with positive symptoms tend to respond well to medication and commonly function normally during remission. The positive symptoms presented here are categorized as alterations in thought, speech, perception, and behavior. Alterations in thought are experienced by all of us. Usually we can catch and correct those errors by using reality testing. People with impaired reality testing, however, make, maintain, and build upon errors in thinking which contribute to delusions. Delusions are false beliefs that cannot be corrected by reasoning. About 75% of schizophrenic patients experience delusions at some time. Student nurses sometimes try to unsuccessfully reason with the patient out of delusions by offering evidence of reality. This is counterproductive, as an even stronger defense is developed for the position. Recall the example we talked about in lab, guys. Also, this may irritate the patient and slow the development of a therapeutic relationship. The most common types of delusions are persecutory, grandiose, or those involving religious or hypochondriacal ideas. So there are various terms that I would like you all to know for the exam, the upcoming exam. I won't go over them all here, but they're all listed on page 205 and 206 in your textbook, okay? They're also found on your study resource guide. The loose associations, clang associations, word salad, neologisms, eccholia, paranoia, okay? All of these words, in addition to circumstantiality, tangiality, all of the words that you see on 206, okay, I want you guys to have a working knowledge of what those mean, because I want you to be able to differentiate between them on the exam. Okay, we talked a bit about this. Alterations in reality testing, delusions or false fixed beliefs, alterations in speech, concrete thinking or the inability to think abstractly. Okay. These are all the terms that I would like you all to become familiar with. Okay. I would like for you to search word salad so that you can have a better example, a visual example. Look on YouTube, word salad, clang associations, neologisms. You'll see these in clinical. You'll see patients exhibiting these in clinical, but just so that you have a forward knowledge of what these are, I would like for you to Google them so that you have an example, okay? Okay, all of these. Alrighty, so let's talk about disorders or distortions of thought. We'll stop here. So this is found on page 208 of your book, of your text, okay? So what thought blocking is a sudden interruption in the thought process, usually due to internal stimuli. So a patient will abruptly stop talking in the middle of a sentence and they'll remain silent. And oftentimes what you'll see is that they pick right back up where they left off as if nothing ever happened. Because what we assume is that the patient believes that what they're hearing you can hear as well. Okay, so it would be appropriate, for example, if I'm talking to one of you and another one of you interrupt and say something and I stop for a moment to process what you said, okay, but that's an appropriate situation. Whereas if I'm hearing something that isn't there, if I'm hearing something that isn't being said and I stop, the person to which I'm talking to may think, okay, that's strange. That is thought blocking. Thought insertion, thought deletion, magical thinking, and paranoia, all of which you can find on page 208. Alterations in perception, depersonalization, derealization, hallucinations, and illusions. Alterations in behavior, catatonia, motor retardation, motor agitation, stereotype behaviors, waxy flexibility, echopraxia, negativism, impaired impulse control, gesturing or posturing, and boundary impairment. Negative symptoms include, again, the absence of essential human qualities. And these are your lists here. On your study guide, you'll find all of the terms that I want you all to be familiar with, okay? These are a lot of descriptive terms that we don't always use in practice, okay? So I don't want you to worry yourself about knowing the specific definitions for every single term. These are terms that psychiatrists are highly familiar with, some not even, okay? But I want you all to know, have a working knowledge of what some of this stuff means, and that of which is very important, that of which you see in practice, I will be testing on, and it is, again, listed on your study guide. And so affect, we talk about mood and affect a lot in psychiatry, and where all of you know what mood is. The mood is internally what you, or what we can describe that an individual is feeling, okay? It's more objective, whereas affect is an outward expression of the person's internal emotional state, or an outward expression of the person's internal mood. So in individuals diagnosed with schizophrenia, you may notice a flat affect, a blunted affect, an inappropriate affect, or a bizarre affect. Okay. Cognitive symptoms include impaired concrete thinking, impaired memory, impaired information processing, and impaired executive functioning. Affective symptoms. Assessment for depression in individuals with schizophrenia is crucial, as we talked about earlier. There's an increased risk for completion of suicide, also an increased risk for substance abuse, and individuals who are experiencing depression may be more likely to relapse into more acute symptom states, and depression further impairs functioning. That goes without saying. So there's this idea of self-assessment, okay? So what we want to jump down here to the bottom, where the nurse's self-assessment is crucial. I often talk about checking in with yourself, okay? In my clinical group, I like to talk a lot about how we are feeling as professionals, as nursing professionals, when working with the mentally ill population. All right, so here the book specifically talks about anxiety or fear, which is a natural state when walking into the unknown, when you really can't gauge a person's mental state. When a person is unable to gauge their own mental state, it's only natural to feel a certain level of anxiety or fear. Okay. Also frustration. Frustration that reorientation to reality is sometimes borderline impossible. When you see an individual cycling in and out of the facility, despite having been equipped with adequate resources, it can become very frustrating. And then your expectations of recovery for an individual may not match that individual's own expectations for their recovery. So, or you may have expectations that recovery is taking place faster, or that a patient is stabilized more quickly, and not really being able to understand the current state of the individual. Forgive me. Okay, so again, I talk about this pretty often, Just being able to check in with yourself, see where you are, and adjust accordingly. Being able to determine whether or not you are able to provide therapeutic care, provide a therapeutic relationship, use yourself in a way that is beneficial toward the treatment and recovery, but also that is safe for yourself, your physical health, as well as your mental health. Okay? When you're assessing an individual with any type of mental illness, specifically those on the schizophrenia spectrum, those of psychosis, you want to be able to assess for any medical problems, okay? Because as you'll see, medical problems can mimic psychosis. We've talked about various medical issues and how we want to always rule out medical conditions, metabolic conditions, lab abnormalities that may be reflected within lab values, any neurocognitive issues such as tumors, etc. We want to be able to rule those things out. Drug or alcohol use disorders, which also can induce and mimic schizophrenia, drug-induced psychosis, alcohol-induced psychosis. We want to be able to perform a mental status examination, which all of you have successfully done so in lab. And we want to include a cognitive assessment, which is that reality testing that we briefly discussed. You want to assess for hallucinations, assess for delusions, assess for suicide risk, assess for the ability to ensure personal safety and health, assess prescribed medications, assess symptoms that impact functioning, and assess family knowledge. Okay. So these are the nursing diagnoses, the specific nursing diagnosis that you would employ for individuals who are exhibiting certain symptoms. So for positive symptoms, disturbed sensory perception, risk for self-directed or other directed violence, impaired verbal communication. Of these three, I probably would prioritize the second, risk for self-directed or other directed violence, and the other two would thereafter follow. For negative symptoms, social isolation or chronic low self-esteem. And from this point, you are going to develop your outcomes and interventions. Okay. So outcome identification, for the acute phase, recall there are various phases, 4 specific phases for schizophrenia. For the acute phase, you think about patient safety and medical stabilization. Okay. For stabilization, or phase 2, you want to help the patient to understand the illness and treatment, stabilize medications, and how to control and cope with symptoms. For phase 3, or maintenance, you want to maintain achievement, prevent relapse, achieve independent, satisfactory quality of life. Planning. Phase 1, the best strategies to ensure patient safety and provide symptom stabilization. Phase 2, stabilization. 3, maintenance. Provide patient and family education. Relapse prevention skills are vital. The acute phase and implementation, you have a psychiatric, medical, and neurological evaluation, psychopharmacological treatment, support psychoeducation and guidance, supervision and limit setting in the milieu, monitor fluid intake, working with aggression, regularly assess for risk, and take safety measures. Stabilization and maintenance phase interventions, medication administration and adherence, relationship with trusted care providers, community-based therapeutic services, teamwork and safety, activities and groups. Counseling and communication techniques, hallucinations, delusions, associative looseness, health teaching, and health promotion. Antipsychotic medications. So we have 3 generations of antipsychotic medications. First, second, and third generation. The first generation antipsychotics, they have the highest potential for side effects, very serious side effects, anticholinergic, as well as extrapyramidal symptoms. And then they sort of taper off with the second and third generations. The first generations are far more strong. Oftentimes we see patients who have failed therapy in the third and second generations. They end up long term on the first generation first generation's antipsychotics. We talk about Haldol often, and Haldol is a first generation antipsychotic. Then you have your injectable antipsychotics, short and long acting. I've talked about this with my clinical group in and I think one of the labs before. Patients who are diagnosed, or individuals who are diagnosed with schizophrenia, because of the very debilitating symptoms that they experience, both the positive as well as the negative symptoms, there is a high rate of non-compliance and non-adherence. So these short and long-acting antipsychotics are greatly beneficial toward treatment when you think about someone who is not going to remember to take their medications regularly, or you think about someone who may be hearing voices telling them not to take the medications, or when you think about someone who does not believe that they are in need of medication, who just really doesn't recognize the seriousness of their illness. So these long and short-acting injectables are injected into intramuscularly, and over a period of time, there's a slow release of the medication into the system. Prior to administering, let me back up. So these can be acting most typically for about 30 days before you have to obtain the next injection. Some are now on the market for 60 to 120 days. It's really interesting to have a drug in the system that long. But again, if a patient is going to be on one of these drugs, they have to have taken failed therapy, and be a strong candidate for it in terms of just, being the provider being able to demonstrate that they are in fact a candidate, in that they will be non-compliant, and also have taken this medication prior. So there's for example a Haldol long injectable. It's called Haldol decanate. It's a decanate injection, Haldol decanate. So an individual needs to have taken Haldol PO orally for enough time to be able to determine that this individual will not have an allergic reaction, because once it's in, okay? So I'll briefly go over these. I don't want you guys to know too much regarding the pharmacology, but first generation antipsychotics are dopamine antagonists. So they bind to the D2 receptor in place of the actual dopamine, okay? So they target positive symptoms of schizophrenia. The advantage of them are they are less expensive than second generation. These are the disadvantages, though. This is mainly what you all need to know, okay? So your first generation antipsychotics, they cause severe EPS, or extrapyramidal symptoms, anticholinergic side effects, tardive dyskinesia, weight gain, sexual dysfunction, or endocrine disturbances, okay? So let me get there specifically to what your book talks about. Okay. So extrapyramidal symptoms are the most common. We usually talk about just like this very rigid stiffness. But specifically what the book talks about is this acute dystonia, or sustained contraction of muscles, usually of the head and neck. And it's like you've never seen before, Okay, then there's this akathisia, or psychomotor restlessness by pacing, fidgeting, sometimes pronounced and very distressing to patients. And there's pseudo-Parkinsonism, and it's medication-induced. It's a temporary constellation of symptoms associated with Parkinson's: a tremor, reduced accessory muscles, impaired gait, and stiffening of muscles. Okay, so when patients start to experience this, generally we stop the drug, okay? But there are other medications that can counter these, such as Cogentin. That's one that's prescribed very often, Benadryl, okay? Lorazepam or Ativan can be helpful in reducing, but generally we stop the medication. So as far as the anticholinergic effects, see how your book talks about these, okay. So the most typical anticholinergic symptoms are dry mouth, urinary retention and hesitancy, constipation, blurred vision, photosensitivity, dry eyes, and sexual dysfunction. And then tardive dyskinesia. So it manifests in the face, protruding, rolling tongue, blowing, smacking, licking, spasmic facial distortion, the limbs, rapid, purposeless, and irregular movements, twisting of the shoulders, the neck, the hips, rocking, and pelvic thrusts. And then you have your weight gain, sexual dysfunction, and endocrine disturbances. The second generation antipsychotics are serotonin and dopamine receptor antagonists. They treat both positive and negative symptoms. They don't have many, if any, EPS or tardive dyskinesia. The disadvantage is the tendency to cause significant weight gain and the risk of metabolic syndrome. For the NCLEX, I want you all to be familiar with this idea of EPS, tardive dyskinesia, and anticholinergic side effects. Okay, know what they mean. It's also on your study guide. Know what they mean and know that this is one of the reasons why and what we need to monitor for when patients have been diagnosed with a disorder of psychosis or schizophrenia and are then prescribed these medications. Okay. Metabolic syndrome. Metabolic syndrome is generally a syndrome, so it's a cascade of symptoms. But when you think of something like insulin resistance or just the inability to process nutrients in an efficient and effective way, that weight gain piece of it is pretty much a pillar of a metabolic syndrome. But also, again, that insulin resistance, sometimes that abnormal growth of hair, or for males, or even females, but mostly, you see it most prominently in males, they develop the breast tissue that was not previously there. That's a metabolic syndrome. Okay. And third generation antipsychotics are really a subset of second generation antipsychotics. They're Abilify. That's the most common one we use. These other two are not typically used. They are dopamine system stabilizers. They may improve both positive and negative symptoms and cognitive functions. Little risk of EPS or tardive dyskinesia. Okay. Only thing about these is that they don't work as well. They really don't work as well. They don't cause as many side effects, but they don't work as well for our very, very chronic patients with schizophrenia. However, some individuals do respond well, like in the early stages of diagnosis. So the potentially dangerous responses to antipsychotics. Please know this. If you don't take anything else away from mental health, please know this, okay? In all areas of nursing, you are going to encounter patients who are diagnosed with schizophrenia, okay? Please know this. People can, and people will, and people have died. So this acetylcholine toxicity. Neuroleptic malignant syndrome, a granulocytosis, prolonging of the QT interval, liver impairment. Okay. So a granulocytosis, the symptoms with this is sore throat, fever, fatigue, malaise, mouth sores, increased infections, and a severely reduced white blood cell count. Okay, that's what it really is. That's a pillar. Severely reduced white blood cell count. It is rare, but the nurse should always be mindful of flu-like symptoms. Okay. Neuroleptic malignant syndrome. I want you guys to look this up. It's on your study guide. I want you guys to look this up and email me if you have questions. Okay. Prolongation of the QT interval. Obviously, that's not good. That has to do with the heart function, and this can result in rapid and nearly spontaneous myocardial events, and then liver impairment. These are your advanced practice interventions, advanced practice nursing interventions, individual and group therapy, psychoeducation, medication prescription and monitoring, basic health assessment, cognitive remediation, and family therapy for individuals with schizophrenia. With regards to evaluation, you want to reevaluate progress regularly and adjust treatment when needed. Even after symptoms improve outwardly, inside the patient is still recovering. Set small goals. Recovery can take months. Active, ongoing communication and caring is essential. Okay, we're going to skip over quality improvement, and we're going to skip over these. Okay, so that's the end of the schizophrenia lecture. Please refer to your study guide. If you have any specific questions, please let me know. Please go through the chapter. If it appears on your study guide, it is extremely important. I thank you very much for your attention. And next, you will have the lecture on bipolar. Thank you.